نرحب ببنتنا رباب جاية أو أختنا الصغيرة رباب. هي دكتورة نشطة ومحبة للعلم، وتبرعت بأنه تقدم لنا كورس، وبذلت جهد وجمعت مجموعة من الأساتذة عشان يقدموا كورس متكامل عن البريست ايمجينج. وهي ذاتها لما كان جاتنا هنا في السودان برضه بذلت جهد، وكان في كورس وكان في تبرع ذاته لفحص النساء. وافتكر ده يعني من فوائد الاطباء، يعني انهم بيخدموا المجتمع، ودي خدمه المجتمع. والان جات خدمه الاطباء، هي خدمت الاطباء وحسب تخدم الاطباء. ونحن يعني انا في نقاشات معاه قلت نبدا من الصفر، لانه بيكونوا متابعيننا ناس من الصفر، فالناس اللي عارفين كثير يصبروا علينا لحد ما نخش في الغريق. عاده المحاضرات انا عندي اساسا ببدا من الصفر، لأنها دي بتسهل الفهم لكل الناس، والناس كلها بتتابع. على حال أنا بشكر جميع الأساتذة الشاركوا وحيشاركوا، والتيم المساعد بقيادة ابننا يوسف مساعد ومعه أصحابه. أفتكر ده جهد كبير، وأنا أفتكر ده نجاح كبير جدا جدا بالرغم من التأخير وكده. وطبعا مسألة التكنولوجيا دي دايرة لها وقت وشغل، والحمد لله نحن تكنولوجيا اتطورنا شديد جدا جدا، وكل كورساتنا بقت بالتكنولوجيا. عندنا دكتور خالد ما مقصر، دكتور عبد المنعم، دكتور الفادني، دول كلهم ناس يعني شغالين شغل شديد جدا جدا. وافتكر يعني دي يعني في تطور واضح جدا في الشغل، وان شاء الله التطور حيزيد، لانه هسه حيجي كيس اوف ذا ويك برضه حيقدموها ابنائنا الشباب. وقبل ما أختم يعني أترحم على جميع من رحلوا عنا في المدة الأخيرة، وخاصة الدكتور مرغني والدكتور تاج الدين، وأيضا الدكتورة العظيمة أخصائية العيون، والاسم طار مني، لكن برضو أخصائية عيون ماتت قريبا بالكورونا. وبعض من قدام اللاعبين في الأشعة مثل الأستاذ عبد الله عثمان ووالد أخونا أمير السني محجوب، وهو طبعا يعني من القامات القديمة في تخصص تكنولوجيا الأشعة والموجات الصوتية. وسبحان الله هؤلاء جميعا التاج السني عبد الله عثمان مرغني كان يجمعهم الهدوء والطيبة والابتسامة وعدم مبزع النزول، يعني كان في common factors between them. ذهبوا في خلال 15 أو 20 يوم منا، وهم السابقون ونحن اللاحقون. اللهم اغفر لهم وارحمهم وسامحنا واعف عنا يا كريم يا رحمن يا رحيم. بسم الله توكلنا على الله. يلا يا بنت الفلور حقك، وربنا يوفقك في هذا الكورس.
الله يجزاك خير. طيب، بسم الله الرحمن الرحيم، وبه نستعين، والصلاة والسلام على سيد الخلق أجمعين، سيدنا ونبينا محمد وعلى آله وصحبه أجمعين. أولا أترحم على روح أستاذي الجليل بروف مرغني، فهو فقد عظيم ولا نقول إلا ما يرضي الله. ونترحم على بروف التاج أستاذ السني وكل من فقدنا على صعيد الأشعة وغير الأشعة من الأطباء وعلى جميع موتى المسلمين. أعجز عن شكري لكم جميعا أساتذتي الأجلاء بروف عبد الله جابر وجميع الأساتذة زميلاتي وزملائي الكرام لإتاحة الفرصة هذه لنتشارك الخبرة في مجال أشعة الثدي. كما أود أن أشكر بروف محمد المعتصم وأختي الدكتورة وفاء ووشاح وسارة المك ومجدولين لمبادرتهم للمشاركة معي في هذا الكورس، وفقنا الله وإياهم. الشكر أجزله لأستاذنا بروف العطايا وابننا يوسف الإشراف والتنسيق. وباسمكم جميعا أتقدم بالشكر الجزيل لشركة سماسو توكيل GE بالسودان، وبالأخص المهندسة العظيمة الرائعة ملاذ ومجهودها المقدر لإقامة هذا العمل. اسمحوا لي أن أبدأ بسم الله to give you talk about introductory talk about breast imaging, mainly the basic imaging used for evaluation of the breast, and highlighting about what is radiology today and advances in technology. طيب بسم الله. As you know, benign breast lesions are more prevalent than breast cancer. However, any patient coming to radiology department, her concern and physician concern is a breast cancer. Why? Because it is the most common type of cancer in women worldwide, representing occur in one in each 8 women, and it's also exceeding all Sudanese female cancer, and the second causing leading cause of cancer deaths among women. And even before we had any meaningful breast imaging, physicians recognized an importance of early detection of breast cancer to reduce breast cancer mortality. And early days, 1924 Radiological Society of North America annual meeting, they stated that early breast cancer cannot be diagnosed by palpation or inspections, and the breast imaging, as you know, is essential in detecting, diagnosing, staging, and providing surveillance of breast diseases and breast cancer. Mammogram remaining the mainstay and gold standard for evaluations of breast cancer, especially for early detections of a non-palpable breast cancer with overall sensitivity of 85%. Coming in the second chair of orchestra of breast imaging is high resolution ultrasound breast, representing along with mammography the conventional modalities, and recently incorporated breast MRI. Okay, regarding the effect of tumor size and survival, as you know, the overall prognosis is directly linked to stage of breast cancer at presentations, and the relations between the size of breast cancer and survival is reciprocal. Whenever the patient presented with a large tumor, her survival definitely will be short, and survival increase when the cancer is picked as a small size. And usually our aim to pick the cancer as smallest as possible when its presence when it's present is still at curable stage. And this is definitely will reduce the cancer-related deaths, and this can be achievable by screening. With a widespread use of screening mammography brought about a new era where mainly palpable cancer being replaced by mainly, this is a palpable cancer, now mainly being replaced by a small non-palpable cancer. So this results in a large number of non-palpable cancer detection, and definitely has a significant impact on breast cancer management. Mammogram is an X-ray modality, which is a gold standard used both in diagnostic as well as in screening setting. This is a mammogram image of bilateral breast cancer seen as speculated mass on the left side and indistinct hyperdense mass on the right side. Also, we can inject iodinated contrast medium inside the discharging duct to see to see the pathology inside the duct, as in this filling defect here. And mammogram is also being used as a stereotactic guided biopsy to remove to take a biopsy of a lesion, especially microcalcifications in this specimen, and can also use to place a wire and as a guidance for the surgeon to remove an unpalpable suspicious abnormality seen on mammography. During evolutions of breast radiograph techniques, the early attempts, it was obtaining a radiograph of the breast at 1920s and 1930s, At that time, Stanford published his successful applications of preoperative breast radiograph to help in predictions of malignant from benign breast disease in 119 patients with histopathologic diagnosis. However, the success was limited due to poor image quality. While optimistic future restarted in 1938 when the issue of radiological entitled early diagnosis of breast cancer. The image on the left here demonstrates, if you look here, there is faintly or very barely seen an opacity at that time diagnosed as infiltrating mass characteristic of malignancy and proven pathologically in this image with these types of soft mammogram due to lack of compressions. Locke reported value of breast imaging showing radiologic pathologic correlations. And the image on the right side here demonstrate the technique of carbon dioxide insufflations used at that time to differentiate a mobile lesion like encapsulated fibroadenoma from the fixed cancer, non-mobile cancer. However, this technique was distressing that eventually discontinued. And if you see here, this is early ductograms, 1939, demonstrated dilated ducts with arperizations of its branches communicating to deeply sited cyst. Compare it with very beautiful high resolutions, similar ductogram at current days with non-dilated ducts, and look how the branching system is very clearly seen and depicted in this image. And also in early days, they used to use the thorotrust as an as contrast medium, but they discontinued to use it because of its inflammatory and radiation danger effect. Regardless of technical challenge, radiologists, they continue support the value of mammography. And 1948, Gershon Gohan was able to demonstrate feasibility of mammography to depict occult breast cancer. And in 1960, Egan described standardized direct exposure mammographic technique, and he found that to be useful for depicting unsuspected cancer and for decreasing the number of mastectomies for benign lesions. This is the Egan technique here. This is the Egan technique. The CC بتظهر حاجات على الشاشة عشان كده. طيب it's okay. طيب here disappear now. This is Egan technique. You see the CC view and the mediolateral, not mediolateral oblique, a mediolateral, direct mediolateral technique. And he was using the ceiling mounted general purpose X-ray with low kilovoltage less than 40 kV. And he's the one who describes the standard technique, positioning the nipple in profile and avoid faults of overlapping structures, using direct exposure film with little or no compressions, and that times the exposure time a little bit long, and definitely it is low contrast image, and by our modern standard definitely they will not consider it as a diagnostic. However, it was reproducible and transferable to other practice, and with this image Egan published one seminal textbook on mammography. Okay. comparison in advances of mammographic technique. Okay, the practice of breast imaging transitions through a wide variety of technical advances. Started from 1930 with this direct exposure film, giving a soft image, and definitely to visualize the thickest part or near to the chest wall, they need to expose the thinner areolar region. And at 1970s, they develop a zero mammography printed in a blue paper, doesn't need a light box. However, though it depicts the breast tissue, giving increased or giving better depiction of the breast tissue, it was shortly replaced by other technique due to high radiation, which is screen film mammography using molybdenum anode and having the capability of uniform thickness breast compressions that improve the depictions and visualization, give better visualization of the breast and shortening the exposure time. And these transferred to the current era of full-field digital mammography at 2005 with more visualization of the and in depictions of breast lesions, especially in a dense breast. A more recent era of digital breast tomosynthesis or 3D mammography, you see, also improve the accuracy of mammography and cancer detections, especially the speculated lesion and asymmetric density in a dense breast, okay, which improve the detection of breast cancer and at the same time the specificity of these and improve the positive predictive value and reduce the recall rate in screening mammogram. Another emerging modality regarding mammographic technique is a dual energy mammogram, or in addition to administration of intravenous contrast medium. As seen here in the image, this is the dense mammogram without contrast, demonstrate here a focal density or focal asymmetry with a suspicious microcalcification, and this is a subtracted image. The both contrast demonstrate avid uptake of the cancerous lesions in the right breast corresponding to that opacity, and furthermore depictions of a tiny suspicious enhancing lesion in the contralateral breast. Definitely, even retrospectively, we could not appreciate it in this dense type of mammography. So in conclusions, the evolution of mammographic radiographic technique started 1930 by direct exposure film mammogram, and at that time the accuracy for breast cancer was 93%, followed by zero mammography that improved depiction of the breast tissue. However, shortly, because of high radiation, shortly replaced by screen film mammography that reduced the exposure times to the full-field digital mammography era, and recently digital tomosynthesis that reduced the recall rate by 30% and contrast enhanced mammographic spectral mammography that improves the sensitivity and specificity of conventional mammography, along with BIRAD lexicon at 1992. Regarding mammographic performance, it is the primary imaging modality with a sensitivity of 85% and a specificity of about 95% and positive predictive value up to 55%. Okay, mammogram is still the only modality proof mortality reduction from breast cancer up to 40%. That is why it is the only appropriate screening modality up to date. However, The most important limitations of mammographic technique is dense complex breast tissue that can reduce mammography sensitivity as low as 30 to 50%. If we look here to compare this extremely dense mammogram with more transparent fat replace mammogram, look, this is tiny opaque lesions could be clearly seen in this transparent fatty mammogram, but definitely even larger lesions here could not be seen. And as you know, the breast cancer is seen as an opacity, and the fibroglandular tissue also is opaque. So there is no contrast between the two, that dense breast is obscuring breast cancer, but not only that, it's also considered to be an independable risk of breast cancer. Other limitations is overlapping structures as is 2D studies, and incomplete coverage is a technical limitations. Severe compression sometimes cause patient discomfort, and this is a cause of the woman escape from the mammographic screening. Risk of damage to implant prosthesis sometimes occur, and interpretations is somewhat subjective, that can lead to missing of breast cancer. And mammogram does not differentiate liquid from solid. Both appear as opaque structures, unlike the ultrasound. Sometimes there is overlapping between benign and malignant abnormalities that consider limitations, and some nature of breast cancer, especially lobular carcinomas that sometimes simulate a normal breast tissue, consider limitations that can easily be missed on mammogram. And one of the important limitations that using ionizing radiations on mammogram and the breast consider a radiosensitive tissue, that is one of the limitations. However, mammogram, the radiation used on mammogram is considered to be safe, which is very low, is 0.5 to 1 millisievert, considered virtually non-existent, equivalent to about 7 weeks of background natural radiations, which is negligible risk is far outweighed by the potential benefit. That is why the ACR and National Comprehensive Cancer Network recommend annual screening mammogram for the average lady start at the age of 40. Okay, using artificial intelligence and the CAD system can overcome some of the limitations of the mammogram by picking small lesions, especially in the dense breast, for the radiologist to further interpret it. You see, and this is approved since early days, 1989 or something, but 1898. But however, the effect of its accuracy in interpretation is still unclear. However, recent studies, they consider or they propose that this artificial intelligence that can approaching the radiologist performance, but is still under study for validation, for clinical validations. And even the CAD system and artificial intelligence undergoes advances technology throughout times. We'll see this illustration throughout our lectures, because the three modalities are the main breast and the basic main breast imaging modality. We finished the first modality, which is mammogram, going to the second chair in the orchestra, which is ultrasound breast, which is considered the essential tool in breast imaging practice, extensively used, especially in the diagnostic setting in adjunct to mammography. It's also used as a screening and can be done as a whole breast ultrasound examination or targeted ultrasound examination and as a handheld technique, as well as a recently incorporated automated ultrasound technique. We said it is commonly used in diagnostic setting. Ultrasound is the first diagnostic approach in for clinical abnormalities in women under age of 30, as well as in pregnant and lactating women with average risk of breast cancer, and can evaluate the diagnostic mammographic or tomosynthesis abnormality. If we look here, these three examples of a mammogram demonstrates, the three cases demonstrates a circumscribed oval opaque lesions. However, in the first case, this oval lesion characterized by unique ultrasound criteria of internal structures of the lesions showing a simple cyst. While in the second example here, it demonstrates a complicated cyst with bright internal echoes, and the ultrasound guidance was completely aspirated and turned to be a benign cyst. While in the third example here, demonstrate a complex type of cyst and proven to be intracystic papillary carcinoma. Ultrasound can be used as a targeted for lesions or abnormality seen on the mammogram or tomosynthesis, as in this example is the non-treated patients with right breast cancer. Follow-up mammogram depict two focal asymmetry on the 2D mammography, and on 3D it seems to be partially speculated small masses. Here targeted ultrasound demonstrate these two nodules as irregular hypoechoic lesions. Again, another examples of these dense mammogram of a palpable abnormality demonstrate here a focal asymmetry. On ultrasound, it's being seen as an irregular, indistinct, non-parallel suspicious mass proven to be invasive lobular carcinoma. Similar example of focal asymmetry in a mammogram. Ultrasound demonstrate an unparalleled, indistinct, suspicious mass proven to be invasive ductal carcinoma. Look how looks similar, but the directions of the lesion a little bit different. This is our case. It is 25-year-old lady presented to us by a palpable hard-fixed nodule in her left breast. On ultrasound, demonstrate just a tenting of the parenchyma with subtle distortion. Look for the component or of the lesions is more or less similar to the background parenchyma, and it's pulling the superficial layer of the superficial fascia. So we report it as a palpable fibrous ridge, and we follow it over about 2 years, was stable. Ultrasound is also helpful in evaluation, assessing of axillary lymph node in the setting of suspicious breast abnormality, and also helpful to guide it for its biopsy. This is a breast cancer, a small breast cancer in the breast associated with this axillary metastatic adenopathy. This one you can say might not be a malignant lymph node, but if we look carefully, this border is a little bit indistinct, and here there is focal asymmetric cortical thickening compressing the adjacent hilum, and that was proven to be metastatic. The other one is highly suspicious axillary lymph node, not only indistinct, but also here breaking through its capsules with complete lack of the fatty hilum and focal area of necrosis. Second look ultrasound. What is a second look ultrasound? Is ultrasound performed after a lesion seen on MRI, okay, targeted by ultrasound to characterize it further and to see if there is abnormality could be appreciated to guide for biopsy. In this case, anticipated ultrasound might be done or might not be done. If it's done, definitely the lesion was not seen on mammogram, on that ultrasound. And this lesion is occult in mammogram. Okay, this is the examples here. The patient having a right breast cancer, MRI performed and revealed oval circumscribed left breast lesion in lower outer quadrant. By MRI here look like probably benign lesion. However, the ultrasound demonstrate an irregular, indistinct, non-parallel suspicious abnormality and guide for biopsy and revealed grade 1 invasive ductal carcinoma. While in the other examples here, the lesion concordant in both MRI as well as ultrasound as a regular oval lesion enhancing on MRI, which was proven to be a fibroadenoma. Why we are doing second look ultrasound to guide for biopsy? Definitely compared to the MRI, ultrasound is more feasible, physically easier, less complex, less costly, more readily available for biopsy and follow-up, and does not require contrast enhancement. Several areas of biopsy can be done at the same setting. Okay, for the superficial lesions, ultrasound is superior to MRI. This example demonstrates a lesion here far away from the parenchyma. You might say, this is definitely a skin lesion. I'll tell you, it might be still a parenchymal lesions. It might be even a breast cancer. Why? We have in the anatomy, the breast is the mammary zones, which contain the gland, is encapsulated or it's present between the superficial layer of superficial fascia and the deep layer of superficial fascia, and anterior to which is a subcutaneous fat and then the skin. But the terminal duct lobular unit sometimes migrate through the Cooper ligaments, okay, to lie more superficially abutting the skin. That is why lesions arising in these terminal ductal lobular unit like fibroadenoma, papilloma, and even breast cancer can be present more superficially and make it challenge for us in breast imaging to differentiate it from a breast. However, ultrasound here is more accurate in evaluating these lesions. See, as in this example of dermal inclusions showing ectodermal signs, signs of a dermal tissue. Ultrasound is also helpful in evaluations the breast implant. If we see here, this is a mammogram, demonstrate this bulge or irregularity in the contour of an implant, what we call it a rat tail signs, but sometimes it reflects lack of integrity of implant or not, or just an incidental findings. But here in ultrasound, if we look, this is a bulge, you see, containing the silicone, and there is underlying stepladder signs signify intracapsular rupture, and this is a radial fold containing silicones. That is why there is a focal intracapsular ruptures, and here the silicone is seen in the breast beyond the surface of the capsule, signify extracapsular rupture with snow storm appearance. Same snow storm appearance seen here in the axillary lymph node, which commonly seen with extracapsular rupture, however, can also be seen with a gel bleed. Not only that, lesions associated with implant or incidentally occur in a patient having implant like a breast cancer can also be diagnosed by ultrasounds. Okay, ultrasound is routinely used and the preferred methods for guidance of imaging guiding biopsy. See, why? Because as we mentioned before, it is easy, and all of these direct visualization of the target lesions, the actual biopsy and clip placement. This is the clip placement is visualized directly, and the needle can be visualized. It is length, you see, and here this is the lesions. This is a clip done, performed or placed on mammogram, and here they would like to take a biopsy, can also be visualized directly. The distance from the skin is also be visualized, as well as the complications occur immediately after taking a biopsy can directly be visualized, like in this case of hematoma, and also can be managed. This like hematoma, it's painful type, and the patient experience pain immediately, so they can do vacuum suctions of that hematoma and relieve the patient on the same setting of biopsy. The only situations mammography is superior to ultrasound in a case of DCIS and the lesion presenting only by microcalcification, which is most of the time is difficult to be depicted by ultrasound. And you know that mammography is the modality of choice in evaluation of microcalcifications. Yes, ultrasound commonly used in the diagnostic setting, but still it has a role in screening setting as adjunct for to mammography to screen patients having heterogeneous or extremely dense in average woman, average risk woman, you see, not elevated risk. Using supplemented to mammography in elevated risk in case of MRI is contraindicated or not available. You see, in this case here of this dense mammogram, ultrasound pick a cancer here. Even retrospective, we don't know where is the site of that lesion. Not only that, this is low-grade DCIS, could be appreciated in this case and pathologically proven, which was not seen in this type of dense mammogram. So in a capable hand, you see, ultrasound can be so helpful even in screening of the breast. And this is example of a medullary carcinoma, you see, in asymptomatic patient of high risk having a BRCA mutations. 6 months after her delivery, she was not lactating. They had done for her mammogram, which was negative, and she has nothing, she has no palpable abnormality, and ultrasound revealed this rounded hypoechoic circumscribed lesions because she's a high risk. Biopsy was done and proven to be a high grade medullary carcinoma. And several studies, they have found that high prevalence of medullary carcinoma in BRCA mutation carriers. Okay, during evaluations of ultrasound, early successful applications of breast ultrasound seen at 1970s, when performed just to determine solid versus cystic nature of breast masses. Look, the image how it was crude. You see, this is mastopathy, this is fibroadenoma, here is a cyst, and this is phylloides tumor. Compare it with current high resolution ultrasound, how it is nice looking, how it characterizes this simple cyst. Not only that, to differentiate cyst from the solid, but with this high resolution, we could evaluate the soft tissue lesions if it is hyper, iso, or hypo, and it is internal structures, if it is heterogeneous or homogeneous, and depict the margins and evaluate for the shape, the complete morphology of the soft tissue lesions. And regarding the cyst, we could differentiate simple cyst with the typical criteria of imperceptible circumscribe, imperceptible wall and posterior enhancement, complete anechoic, differentiated with a complicated cyst like this with glittering appearance due to echogenic foci, as well as a complicated cyst with debris fluid levels going toward the complex type of cyst associated with soft tissue abnormality. Regarding the performance of ultrasound, having a reasonable sensitivity. When adding to mammogram, it improved the sensitivity up to 91%. Ultrasound has no medical contraindications. We can do breast ultrasound for all women, regardless. She's pregnant, she's lactating, she's very sick, she could not stand, she could not lie prone, she could whatever. We can do ultrasound breast at all time. No medical contraindication. It can solve the problem at all time, and it can detect a lesion regardless of breast density. See, it proved excellent modality as a subsequent evaluation of BI-RAD 0 mammogram. However, like other modality, having a limitations, and its major limitations is operator dependence. If we look here for these examples, this lesion is the same as this lesion. However, the observers are different. The first observer showing the lesion as soft tissue, low suspicious mass for biopsy, while the other observer demonstrated as an echoic cyst. The other limitation is time consuming. It requires more physicians' involvement. The American College of Radiology Imaging 6666 trial of breast ultrasound screening, they found that out of 40 cancers diagnosed, 12 of them diagnosed only by ultrasound. So ultrasound proven to be an excellent modality in cancer detections, especially in patients with a dense breast. However, it leads to higher recall rate. Why? Leading more to unnecessary biopsy by factor of 4, because it has a poor sensitivity. It has a lot of false positive rate. Many lesions, see, benign lesions on ultrasound simulating breast cancer. So not typical benign lesions. So it needs to be biopsy. When combining with mammography, increase the false positive rate to 10.4% compared to 4.4% for mammography alone. So it has a low positive predictive value, and still screening ultrasound does not prove a mortality reductions. And because of these limitations, these can considered as a current barrier to widespread adoption of ultrasound as a screening tool. Okay. This is the automated breast ultrasound technology, you see, performed by a technologist, saving the image later to be reviewed by the radiologist. So it can overcome the limitations of time consuming, and especially for the radiologist. And for that reason, they propose it as a potential solution for whole breast ultrasound screenning. And it found the preliminary studies demonstrate similar cancer detection rate as compared to the handheld ultrasound. Also, the automated ultrasound is standardized the scan, saw, and lack of operator dependence limitations of the handheld ultrasound. This is the image of automated breast ultrasounds, volumetric acquisitions, and multiplanar reformatted images demonstrate this benign lesion, while this is the cancer lesions here, and the distance from the nipple, and other cancers here, and this is the marker at the site of nipple. Okay. Regarding advances in ultrasound technology, the harmonic imaging, when adding to the grayscale, improves the conspicuity of the lesions. In this case of a DCIS, look here, we can suspect there is something here not very clearly differentiated from adjacent fatty breast. After adding the harmonic, the conspicuity of the lesion is becoming very clear. Even we could appreciate the borders are indistinct and irregular, make it a suspicious lesions. Also, elastography improved the specificity of the ultrasound, especially for BIRAD 3 and BIRAD 4 indeterminate lesions, and also improving ultrasound accuracy by adding contrast medium. And this is example of a gray scale irregular parallel mass. We can see it with breast cancer, and they can say it might be a fibroadenoma, or however is not very typical, having a suspicious features. But when we add the contrast, the irregularity of the lesion is much more appreciated. In addition, we can see a perfusion defect, we can see multiple radial vessels, all are constellation of improve the or increase the suspicious level of the lesion, and this case was proven pathologically to be intraductal papillary carcinoma. And these are examples of benign as well as malignant lesions with contrast enhanced ultrasound compared to the grayscale. Regarding the benign lesions, I have here hyper enhancement lesion, iso enhancement, and hypo enhancement lesions. However, all demonstrate the similar size as well as similar shape and margin to the grayscale without showing increased size. While in these malignant lesions here, you see hyper and some hyper with perfusion defects as well as iso, but they are showing some increase in size, vascular defects, and indistinct margins signify that suspicious abnormality. Furthermore, also like on MRI, we can do time intensity curve for contrast enhanced ultrasound, and in this case, this is the morphology of the lesion, hyper enhancing, you see, with perfusion defect, as well as a penetrating vessels can be visualized or are suspicious features. When we look for the time intensity curve, look for the peak, how reflecting strong, fast enhancement time intensity curve. So we finish from the mammogram ultrasound. Let us go for breast MRI, which is a clinical application began in the mid-1980s, quickly gained interest due to high sensitivity because the contrast enhanced the breast cancer is sensitive for contrast enhancement regardless of the tissue density. It's also used in diagnostic as well as screening setting, and as we see here, it has facility to guide for biopsy. These are multiple images of breast MRI showing a linguine signs and collapsed implant. This is a high resolution maximum intensity projection delineating ductal carcinoma in situ, as well as intra-mammary lymph node, sharply demarcated here. And this is speculated enhancing mass due to invasive breast cancer. And this is T2 image demonstrate multiple breast cysts. However, the lesion here demonstrates some irregularity and hyperintensity in the surrounding parenchyma. However, post-contrast image revealed that this abnormality due to inflammatory nature of that cyst. And the example here demonstrated bilateral ring enhancing, irregular ring enhancing lesions, you see, which are suspicious for metastatic breast lesions, proven to be pathologically proven. And this is a corresponding PET scanning demonstrates similar hypermetabolic with the same appearance of the MRI. MRI proved to be excellent in preoperative staging of breast cancer, depicting mammographically occult lesions. You see, and definitely this is very important for better treatment outcome. This is the example of a mammographic suspicious abnormality, pathology proven lobular carcinoma corresponding to the laterally placed enhancement lesion on MRI, but furthermore, it can depict this lesion in the medial aspect of the breast, biopsy proven to be another focus of lobular carcinoma. Definitely, this will preclude the conservative management as a treatment choice. Another example of multicentric breast cancers, the index lesion here, and multiple, you see, scatter foci in the rest of the breast, and this a case of multifocal disease, seen multiple satellite nodule in the vicinity of the index lesion as well as axillary lymph nodes. And in this case, MRI depicts an occult contralateral malignancy not shown on conventional images. And MRI is also helpful in demonstrating a Reuters node, interpectoral nodes, as well as the internal mammary node, which was not easily seen, or which are not easily seen in conventional images. MRI is also very helpful and sensitive for occult cancer in case of metastatic axillary lymph node with sensitivity approaching 86%. An example of this case having left breast mastectomy for breast carcinoma, and her ultrasound and her mammography and ultrasound follow-up demonstrate no breast lesion, however, suspicious axillary lymph node, biopsy proven to be metastatic adenocarcinoma. And the MRI of these patients demonstrate here an irregular enhancing mass in the anterior half of the breast, and the color-coded overlay kinetic image demonstrate red color, signify type 3 washout curve, which is suspicious, and post-biopsy revealed high-grade invasive ductal carcinoma. Regarding the disease extent, still, these are examples here. This is a locally advanced breast cancer, demonstrate adjacent thickening of the skin with query invasions, but MRI here clearly shown the infiltration of the adjacent skin by the adjacent cancer, okay, and with thickening and ulcerations and enhancement. This is the same lesion, and in the other example, look for the lesion, how it's extend and infiltrating into the nipple areolar complex. And this lesions here is posteriorly placed lesions in the prepectoral area, infiltrating into the pectoralis seen on the axial. However, in the sagittal view, not only the pectoralis, but it's shown to be extending deep into the intercostal muscles, signify chest wall involvement, which definitely affects the strategy of breast cancer management. And this mammogram here, we can see the lesions projected over the pectoralis, but due to overlapping of breast tissue, and we don't know if the pectoralis is involved or not. We just raise the suspicions for that. However, the capability, the multiplanar capability of the MRI, we could appreciate the lesion that is far away from the pectoralis, and it is spared from the disease involvement. Continue for breast cancer disease extent. Here, this is locally advanced cancer. That is the lesions infiltrating into the adjacent skin with multiple skin enhancing nodules signify infiltrations by the disease. And here, this is a corresponding PET scan showing the hypermetabolic avid FDG uptake of the primary index tumor, and to lesser degree, the uptake seen in the skin nodule in invasive skin due to the skin invasions. Again, this is direct invasion of the skin. Look how the nipple areolar complex infiltrated by the mass here with global skin thickening and enhancement. MRI is also the modality of choice to evaluate for inflammatory breast carcinoma. It can depict the primary lesions in up to 98% compared to 65% mammographic sensitivity. Why? Because usually in inflammatory breast carcinoma, the lesions are small interconnecting nodule rather than the usual larger mass seen with other type of advanced or non-advanced cancer. And on mammograms, these small lesions will be obscured by increased density due to parenchymal as well as skin edema and increased density. While capability of contrast enhanced MRI that help in depicting these types of the lesions. These two examples of diffuse inflammatory breast carcinoma showing the remarkable skin thickening and enhancement. Look for the enhancing nodules here. And in this example demonstrates non-mass-like enhancement, extensive reticular dendritic type pattern, while here this is an irregular, intensely enhancing mass, is trained to have type 1 benign type intensity curve. And this is a third example of focal area of inflammatory breast carcinoma with dendritic reticular non-enhancement-like pattern, as well as overlying focal skin thickening without evidence of direct invasions due to lymphatic infiltrations in inflammatory carcinoma. MRI is also proven helpful in differential diagnosis, okay, and can help in diagnosing chronic granulomatous mastitis, much more than the conventional images. Though the image here, it looks suspicious with non-extensive irregular area, heterogeneous area of non-mass-like enhancement extending to overlying skin. You see, with the skin thickening and enhancement also demonstrated here. However, if we look in this image, subtracted image here, we can see multiple ring enhancing clusters of multiple tiny ring enhancing lesions signify micro abscesses of inflammatory conditions in a case of granulomatous mastitis. MRI is helpful in monitoring the response of neoadjuvant chemotherapy, and the examples here demonstrate the enhancing mass on a baseline ultrasound compared to post-chemotherapy treatment. There is no more enhancement and the lesion is not well appreciated, so they need to put pre-therapy treatment a wire to guide the surgeon to remove the lesion post-chemotherapy treatment. Look for this example. The lesion here is significantly regress in size, while these lesions showing complete lack of enhancement with minimal residual area. While look for these examples here of irregular large lesion is almost completely gone in post-treatment and was proven to be pathological complete response. So MRI proved to be helpful in differentiating pathological complete response from non-pathological complete response patients. Okay. MRI is also helpful in post-surgical evaluations. In these examples, look for this seroma cavity, the patient having positive margin, MRI done after surgery, demonstrate a bulky residual cancer posterior to the seroma cavity. While in this example, patient having lumpectomy for breast cancer, and the first follow-up demonstrate here in non-fat SAT the area of irregularity due to the scarring with central area of fat intensity associated with faint enhancement in fat SAT on subtracted images, and this is typical and consistent with a fat necrosis. However, follow-up revealed an irregular intensely enhancing mass, bulky mass replacing the area of scarring, along with more satellite disease signify cancer recurrence. In this third example, this lady after 13 months post wide local excision presented with erythema and thickening around the nipple and areola, you see? And her MRI demonstrate this is a seroma cavity with multiple irregular enhancing masses. The anterior one is infiltrating into the nipple areolar skin. That is why it's seen clinically as erythema and thickening due to direct invasions here, extending toward that side of the skin. And was pathology proven to have a recurrence. Look here, this is the same appearance of the lesion seen on mammogram corresponding to hypermetabolic FDG uptake in PET scanning. MRI is also helpful in evaluation of prosthetic as well as autologous breast augmentations and or reconstructions, and demonstrates the type of implant prosthesis. This is a single lumen implant prosthesis, while this is a double lumen in the same patients. Here, silicone seen beyond the capsule signify extracapsular rupture, and this is a collapse implant and linguine sign, but at this level, we can see it also on mammogram. However, MRI can pick early focal intracapsular ruptures, as in this case here, subcapsular line indicate focal, and this is a solid oil or droplet sign signify focal intracapsular ruptures. And in the third case, apart from subcapsular line, there is also teardrop sign indicate intracapsular rupture without implant prosthesis collapse. Compare this, it is due to silicone inside a radial fold compared with a usual radial fold, not signifying a capsular ruptures. Okay, not only integrity of the implant, but also diseases associated with implant can be appreciated with MRI, like this capsular hematoma, cancer associated with, in a case of a patient having implant, seen here on mammogram as area of calcifications, but very clearly depicted by MRI's irregular enhancing lesions, and also evaluate for inflammation of the capsules. You see, sometimes presented with pain, thickness, and in conventional images is difficult to be evaluated, and in this case demonstrate here reactive internal mammary node. MRI is also helpful in evaluation reconstructions post mastectomy, and in this case of latissimus dorsi autologous reconstructions showing no abnormal enhancement, while in this case here in the reconstructed tissue demonstrate multiple enhancing. Here, this is the same patients here, demonstrate signify disease recurrence, and also in the case of autologous fat reconstructions, autologous fat injections or fat transplant can represent a fat necrosis, will be appreciated on MRI. MRI is also helpful, is also playing important role in screening for breast cancer for both high and currently recommended also for moderate risk of breast cancer. High risk breast cancer, as you know, those patients or those female having 20, 25 or more risk, lifetime risk, those having a BRCA mutations or other type of genetic mutations, having a strong family history of breast or ovarian cancers, and those who have who have history of chest radiation, mantle radiation, like for that of Hodgkin lymphoma at the age between 10 and 30 years time of breast development. And regarding the moderate or elevated risk, especially for the personal history who have a dense breast or diagnosed before the age of 50, the current recommendations is to do for them a screening MRI along with a mammography. Why not only MRI? Because it might miss some cancer being picked by mammography. So both are complementary as alternate, doing annually for high risk as well as intermediate or moderate risk. And this is example of a dense breast. Mammogram doesn't show any abnormality. MRI demonstrate a 4 centimeter lesion proven to be high-grade ductal carcinoma in situ. Regarding performance of MRI, it is an excellent sensitive modality for invasive breast cancer, reaching up to 100%. And this is far more accurate modality in diagnosing and characterizing breast malignancy than either mammography or breast ultrasound for both invasive cancer as well as depictions. It can depict the DCIS component associated with breast cancer in up to 95.1% compared to 3.2% of conventional imaging. It's the most sensitive modality for diagnosis of high and moderate grade, but not a low grade DCIS. And it's the best modality assessing the residual disease, and it is a highly sensitive for detecting tumor recurrence with high negative predictive value, differentiating the scar from the recurrence. It's correlated best with pathology. Cross-section overcome limitation of overlapping structure in conventional images, and ability to include the chest wall and axilla give us good anatomical coverage and uninfluenced by breast density and complexity of fibroglandular tissue as on mammogram. And it is safe as it doesn't having ionizing radiation. And currently it has facility to guide biopsy as well as BI-RADS lexicon for reporting. However, like other technique, having a limitation, especially its specificity is relatively moderate rather than high specificity, and positive predictive value is about 20 to 50%, as not all lesions enhancing abnormality seen on MRI are cancer. A lot of benign and proliferative lesions can be enhancing, so it results in a lot of false positive. So that is though is not is not as high as ultrasound, but it increases the additional need for additional investigation by factor of 2 and additional unnecessarily biopsy by factor of 3. Also, the cost, time, accessibility, and IV contrast can be considered limitations for the MRI, and the variability of an heterogeneous background enhancement of normal breast tissue that influenced by menstrual cycles sometimes can result in a limitation. And in this case, look here, this is marked background parenchymal enhancement. Definitely, we call it dense MRI breast. It will obscure small enhancing mass or non-mass like enhancement. You see, there is no standard technique, so marked variability in quality of exam can be considered some of the limitations, and still there is no data on mortality reduction regarding the screening MRI. And as we mentioned, it is much more sensitive, having a high sensitivity for high and moderate grade of DCIS. However, its sensitivity for low grade is a little bit less. That is why reducing its sensitivity to about 40%. Using both kinetics as well as morphology criteria can just improve and overcome some of the limitations of the MRI. This is our case. If we look here, definitely by morphology, this is a highly suggestive of malignancy. But looking for the kinetics, it is type 1 benign curve. But that is why, because that patients having a lot of the component of ductal carcinoma in situ rather than invasive cancer. This is the case from the literature. 27-year-old woman having an oval, regular, small 7mm lesions. You see, by morphology is relatively looking like probably benign lesion. However, when look for the kinetics, you see, it demonstrates type 3 curves. So for that reason, biopsy performed and revealed to be invasive ductal carcinoma. So to overcome the limitations of MRI, and we have to correlate it always with conventional imaging. Whenever you put MRI here to be reported, put your mammogram and put your ultrasound here and correlate it with this modality. And it should not be done or be used improperly in place of ultrasound, which is more available, more easily performed. Sometimes some clinicians from the beginning, before requesting mammogram or requesting ultrasound, just directly jump MRI. We should not accept to do MRI breast for a lady before starting by a conventional imaging. Because of the above limitations, we said MRI is not an appropriate screening tool for general populations. However, it is recommended for elevated risk. And for this group, it proved to be an excellent screening modality when supplemented mammography, increasing the sensitivity to 92.7%, while combining ultrasound with mammography in this group, the sensitivity is only 52%. Also, MRI is proved to be so beneficial, particularly in some of subgroup of breast cancer, including invasive lobular carcinoma, triple negative or basal carcinoma, luminal B and HER2 carcinoma, intermediate and high-grade DCIS, and in particular useful in younger patients with a dense breast, and demonstrate and showing much more disease extent than mammography. Look for this example here, 39-year-old lady with extensive DCIS depicted as pleomorphic suspicious calcifications here. Look, this is a nipple. The calcification, it doesn't show extension down to the nipple, but look for the corresponding MRI of the same lady and the extent of the disease from the back prepectoral region going down to within the nipple. So definitely this patient is not appropriate candidate for nipple sparing mastectomy. Okay, using the CAD system in case of MRI, which is a dedicated software, can be used in a workstation or in relations or related to the box. You see, is helping saving the technologists and radiologists time by up to 30 minutes. Instead of doing post-processing manually, doing by the CAD system, it also can facilitate the movement and improving the movement related findings and improve the accuracy of breast MRI by reducing the false positive diagnosis, provide standardized image processing, and promote reproducibility and consistency and accuracy. This definitely will provide a good quality, provide a quality control, and it enhances communications. So CAD system is also have 3D color mapping imaging, and here look for the red color. Red color signify a washout curve, and here there is kinetic heterogeneity. So we can select the area of red to see the most suspicious type of kinetic curves. However, not all MRI machine having these capabilities. Advances of the MRI, including angiogenesis mapping, mapping for axillary lymph node for pre-therapy. You see, to visualize this, all the involved lymph nodes, it will be helpful for the surgeons, you see. And this is post-processing type, they call it shape encoding rendering, demonstrate this and highlighting this suspicious node, which was not seen in the routine usual MRI. Also, diffusion weighted imaging is helpful in evaluating and delineating suspicious axillary lymph node, and in this case, proven to be metastatic, and the diffusion weighted here, it is bright, and in the color ADC color coded image, it was blue with the ADC value signify or denoting restricted diffusions. You see, not only for the lymph node, diffusion is also helpful in evaluation of the index lesion, and in this case, look for the peripheral enhancement for the viable tumors and non-enhancement of the necrotic, followed by the same area bright on diffusions and restricted on the giving restricted number of on ADC mapping. This is example of how diffusion is helpful in differentiating of benign and malignant breast lesions. If we look here, this lesion, it looks similar, but these are different, two different patients. You see, this is an oval circumscribed hyper-enhancing mass, you see, and these are same shape, morphology, and enhancement, two lesions. On diffusion, both are the three lesions, the two adjacent here and these lesions are bright. When we go to the ADC, this demonstrate a low signal, signify restricted diffusion in a case of invasive cancer, while these two are still bright on ADC, signify absence of restricted diffusion in a case of fibroadenomas. MR spectroscopy, recently incorporated for the breast evaluations, which is probing the chemistry of breast tissue, non-invasive technique, depending on acquisitions of pulse sequence to determine the choline metabolites in the breast, reflecting cellular proliferation associated with malignancy. See, they found it a promising applications for treatment response when they do a baseline spectroscopy, and 24 hours after the first dose of chemotherapy, they found it can predict the response to that chemotherapy treatment, which is very important technique in this. This is the choline, you see, it is seen here at the level of 3.22 ppm. While the presence of fat here, this is a contaminations because the breast was not homogeneously subtracted from the lipid. And the normal breast parenchyma, when it is not subtracted the fat, definitely is rich, is a fat rich. Look here, the only metabolite is seen is lipid. This is the normal, while the normal parenchyma does not contain choline. Including the recent technological advances is what is called perfusion mapping, which is a functional imaging playing important role in prediction of treatment therapy. Compare the pre-treatment breast cancer here with post-treatment and complete response, and even look for the amplitude here in the curve, how it is elevated, and now how it is flattened in post-therapy treatment. Okay. Nowadays, there is an revolution era looking for new breast cancer radiologic terminology and classification system based on the anatomic site from where the lesion is being arised. Is it from terminal lobular ductal unit, from the major lactiferous duct, or from the stem cells of the mesenchymes? And these, as you know, definitely affecting definitely having different histopathological appearance as well as clinical features, and require different type of treatment and having a long-term outcome. For the trend now to dig deep in the radiology to classify these types, pathological types, and paralleling the pathology. And these are examples of MRI phenotype of breast cancer, kinetic assessment of molecular subtypes. This is HER2, this is luminal, this is triple negative, and luminal P. Inshallah, later when we talk about advances, we can dig deep in these types. Recent technical advances also including advance and improvement in the breast coil. They are doing more dedicated types of coil to give better fat suppression and higher resolution scan. The new 3 Tesla having twice details than older 1.5 Tesla scanning to detect breast cancer earlier, more accurately, especially when coupled with latest 3D color flow computed aided diagnosis software. Look for the image, how it delineating the DCIS down to within the nipple, you see, and also using the ultra-fast dynamic contrast enhancement techniques, you see, can generate a kinetic parameters which prove to be effectively differentiating sub-centimeter cancer to be differentiated from benign lesions on MRI. Another new techniques, which is only T2, heavily T2 weighted images. See, look for this image, is a heavily T2 weighted images, can give us what is called MRD, or magnetic resonant ductography. You see, compare it with the conventional ductography here, showing both of which showing a dilated duct with, this is a filling defect and this is a signal defect on the MRD. When doing MRM, which is the routine magnetic resonance mammography, you see, with contrast, demonstrate an enhancing ductal lesion here, and with the software, they fuse the MRD and MRM, and here demonstrates the green color is a dilated duct, and the red area is an enhancing lesion. So it demonstrates that the lesions, the enhancing lesion is related to that dilated ducts in a case of intraductal papilloma. A similar technique here in a case of invasive breast carcinoma. This is the MRM and the enhancing area, and this is the MRD, you see, and demonstrate multiple irregular filling defect and ductal system, as well as multiple cysts corresponding to the conventional mammography. The fusion image demonstrates this infiltrating mass is related to this abnormal ductal system. Nowadays, they are abbreviating the technique of MRI and shortening to only pre and single post contrast image in a 10 to 15 minutes compared to 45 to 1 hour time of usual MRM, so as to be used in a case of screening to improve the access of breast MRI screening for a wide populations. You see, this is definitely, it will shorten the protocol and minimize the time and minimize the cost. But and they found that it is useful in picking and diagnosing breast cancer, but it will be only by morphology. They will look for any abnormal enhancement. They cannot characterize it further by kinetic criteria because there is no dynamic post-contrast study. Okay. MRI, mammography, ultrasound, and breast MRI are the standard recommended radiological examinations. However, there are many other techniques can be used to evaluate for the breast, but at current is still controversial and not appropriate as a screening use only in conjunction with traditional technique. These include a dedicated breast computed tomography, which is a new imaging modality. It is a comfort because not using breast compressions, and the large breast can be accommodated, not like a 2D mammography, at the same moment using the same radiation dose of the digital mammogram, and can overcome also the limitation of breast density and presence of implant of the 2D mammography. It provides 3D data that can be reconstructed in different planes like MRI, and it is less expensive and more quicker than the MRI, you see? And it's having software allow window and levels and magnify, adjust the slide thickness, measure, annotate the area of concern. This is examples of dedicated breast tomography showing a mass here, cross-reference between 3 planes, sagittal, axial, and coronal, and this is maximum intensity projections. Another type of computed tomography, however, in this case, it's also non-invasive, new promising technique. However, instead of using X-ray, they are using optical imaging with a laser camera that illuminate the blood supply to the breast and can pick or detect any new vessels depending on angiogenesis that can differentiate benign from malignant. And it has also 3 dimensions cross-sectional images of the breast, and it used also in adjunct to mammography in a dense breast. Look for this area here. You see a suspicious area seen on the image as a more suspicious, and the patient is lying prone like on MRI. Computed tomography. As you know, computed tomography and PET CT both are used for systemic staging for breast cancer, especially for advanced stage 3 and 4. And if you look here, this is the patient with right breast cancer with axillary lymph node, and demonstrate here ipsilateral internal mammary lymph nodes by size criteria, and being ipsilateral might be a suspicious one. However, by using PET scan showing hypermetabolic uptake, which improves the diagnostic accuracy over the just morphological abnormal CT. And this is a PET scan here, demonstrate recurrent breast cancer in supraclavicular mediastinal along with axillary lymph nodes. You see, PET scan demonstrate abnormal metabolic activity. Also, the breast can be evaluated in the whole body PET scanning, and this is example of inflammatory carcinoma showing diffuse heterogeneous or widespread heterogeneous enhancement, skin thickening and enhancement. Also here, the PET demonstrate huge mass with intense FDG uptake, you see, as well as thickening and enhancement of overlying sting corresponding to MRI findings, and in this case, similar huge metabolic FDG uptake in a breast cancer mass along with internal mammary lymph node. While in this case, ultrasound demonstrates an irregular hypoechoic lesion proven to be invasive carcinoma, but difficult to appreciate the posterior aspect of the lesions, while in this PET scan, not only we could see the posterior, but even the extent and infiltration into the underlying pectoralis muscle, sparing the chest wall, as well as this metastatic axillary lymph node. We have seen the breast in the standard a whole body PET. However, nowadays there is emerging molecular imaging as a dedicated breast imaging or PET scanning of the breast using the same FDG radiopharmaceutical. The machines here, you see the patient is lying prone like an MRI and give a more superior spatial resolution compared to MRI, however having a higher specificity. Look for this MRI, compare it with the BEM or the positron emission mammography, showing similar lesions, you see, with ring enhancement and adjacent satellite nodule. And because of radiation is not recommended for breast cancer screening, but often used when MRI is not feasible. It has also 3D tomographic image, thus the image can be re-sliced in different planes, not only MLO, and also the radio tracer quantifications, you see, give a capability to monitor the effectiveness of the chemotherapy treatment, and this is very easy to learn by the radiologists regardless of their experience. And BEM having a lexicons providing standardized reporting like the PIRAT system, breast, MRI, and ultrasound, and it has also MRI biopsy guided facility. These are examples demonstrating the whole body, the breast image in a whole body BEM. You see, this is a suspicious lesion here in the whole body, and the same lesion seen in a dedicated positron further demonstrate adductal extensions from the lesion not shown in the whole body, so it gives more high resolution, and in the other examples demonstrates an occult intramammary lymph nodes not seen in the whole body image. Example, the BEM compared to the mammography. Look for the positron emission tomography, how it demonstrates these hypermetabolic lesions. Compare it with this, even retrospective is very difficult to appreciate the lesion. And here we can difference in the glucose metabolism in the tumor relative to the surrounding dense tissue. Compare it with the difference in structural changes between the density of the lesion compared to the surrounding, to the density of the surrounding parenchyma on MRI. Definitely, the functional images here is much more superior than the anatomical structural images. Again, this is an example. Look for this radio opaque marker, signify a palpable, put it at the site of palpable abnormality. We can see vague focal asymmetry here because of the presence of the marker, otherwise difficult to be appreciated. But look for the BEM, how it appreciates the cancerous lesion here compared to this type of dense mammography. Another examples of mammogram showing a suspicious positron emission mammography performed demonstrate another large lesions apart from that detected on mammography. Another molecular study, emerging molecular study called scintimammography. Simulate having the machine, if you look for the machine here, it is similar to mammography machine. However, instead of X-rays, using a specific chemical, injecting a radiopharmaceutical, which is technetium-99M, is why they call it scintimammography. See, it's giving a high resolution functional imaging with a sensitivity of a 95 and a specificity of 80, you see, and it's also comparable to breast MRI, having similar performance in detections of occult breast cancer. But also because of radiation is not commonly used, if MRI is not feasible, using replacing, and it also can be used to identify sentinel node. Scintimammography is proven to be accurate in BIRAT-0 mammographic lesions with a performance of 84% accuracy compared to ultrasound accuracy of 56%. We usually, for dense breast, we used to do ultrasound. However, scintimammography is much more accurate than ultrasound. However, if we have a suspicious mammographic abnormality, BIRAT-4 or 5, and the scintimammography is negative, we should not preclude the biopsy. We have to proceed and do biopsy based on mammographic suspicious features. Okay, and also having a biopsy capability. These are examples here: dense breast showing nothing, and this is the lesions seen on scintimammography. Another examples of dense breast doesn't show the lesions seen on scintimammography. Here we can see the largest lesion as faint or vague focal opacity. Look, it's clear with even adjacent satellite nodules. And these lesions also, if you compare it, is very obviously seen in scintimammography rather than in a dense breast. Thermography or digital infrared is based on human body, thermally symmetrical, and increased surface temperature due to angiogenesis of the breast can be imaged by infrared sensor camera, okay, and proven to be effective detecting cancer earlier than any other modality. Very sensitive, non-invasive, no radiations technique, painless, okay. However, FDG cleared the device since 19 as adjunct to breast cancer diagnosis, not as the first tool. It's still not approved to be a first tool in screening or in diagnosis. Is not appropriate modality. We'll go back to the basic imaging modality, which are mammogram, ultrasound, and MRI. And we finished the talk about the evolution of these techniques, and we mentioned that 1992 they developed BIRAT lexicons for mammography, and at 2003 they developed another one for the ultrasound and MRI. So what is BIRATs? BIRAT is breast imaging reporting and data system. This is the abbreviations: breast imaging reporting and data system. So the American College of Radiology at 1992, in response to request of the referring physician, they developed BIRAT mammographic lexicons. At that time, the mammogram was the sole specific imaging modality. And the first structured imaging language being performed for all imaging, not only for the breast imaging. Nowadays, you know, they refer to the BIRAT of the breast, and now there is THIRAT for the thyroid, BIRAT for the prostate, LIRAT for the liver, and ORAT for the ovary, and so on. Okay. At 2003, incorporate BIRAT system for ultrasound and MRI lexicons, as we mentioned, and they updated to 2013 as the 5th edition for mammography and the 2nd edition for ultrasound and MRI. So the standardized image reporting reduces the confusion in imaging interpretations by providing common language among radiologists, using easy understanding terminology and consistently used by interpreting physicians. So definitely this would facilitate communication between radiologists and referring physician regarding the significance of finding and management recommendations. And it includes 3 components: lexicons of descriptions, report organization, and framework for data collection and editing. So the structured or the standard structure reporting should include descriptions for the clinical indications of the study first, then the breast composition in all modality, not only in mammography, ultrasound, as well as MRI. And then after that, describe the important findings. And if we have a previous study, we have to compare it with, and accordingly, we can conclude these to final assessment category, according to which we can give a management recommendation. And if there is any unsuspected finding, we have to raise the phone and communicate with the referring clinicians. So the final assessment categories include BARAT 0. If we could not evaluate the abnormality, either the breast is extremely dense, or we could see something, we don't know if it is real abnormality or not, or something, we need to characterize it further. See, if we need to characterize it further by either doing spot compression view or doing ultrasound or compare it with the previous, so it will be BARAT 0, BARAT 1 if the study is negative. No further workup. So resuming the routine screening, because the risk cancer is almost 0%, same as for benign findings, which represent BARAT 2, while BARAT 3, the lesion is probably benign with a high probability to be benign. However, since there is still some risk, though it is below 2%, we have to follow the lesion so as to ensure not missing a cancer abnormality. And in this case, biopsy should be recommended, but because the range of risk from above 2% to below 95%, they subdivided into BARAT 4, A, B, C, and D. And BARAT 5, the lesion is highly suggestive of malignancy. Appropriate action should be done, and if pathology coming not to be malignancy, we have to repeat the biopsy in these cases. And BARAT 6, it is known pathology proven malignancy, but just need to have further imaging investigations. So we talk about the evolutions of imaging using ultrasound, MRI as complementary to mammography, the additional algorithm, and just we have to go through the breast interventional procedures. And as you know, early days, 1960s and 70s, there was little mammographic screening for the usual care. And at that days, to diagnose breast cancer, they need to do open surgical biopsy. You see, the practice, it necessitates a lot of surgical removal of multiple benign lesions for every diagnosis of breast cancer. And the challenge was for the lesions, for the mammographically suspicious lesions, but clinically occult. cannot be palpable. So the surgeon need to remove large quantity or large amount of breast tissue, sometimes the whole quadrant to be removed to ensure the lesions seen on mammogram is being included within that lesions. However, at 1976, percutaneous biopsy using needle aspiration with stereotactic guidance is being started, and preoperative mammographic localization initially was performed at 1985 and ultrasound guided biopsy at 1989. Definitely, this improves the ease of obtaining a tissue diagnosis for clinically occult mammography suspicious lesion, which increase effectiveness of screening mammography and reduce breast cancer deaths. And this also will reduce the re-excision rate and therefore decrease the morbidity and improve the breast cosmetics, avoid open surgery for benign lesions, and proceed directly to definite therapy of breast cancer. So the recommendations now is image-guided percutaneous biopsy. It's considered to be the first approach for tissue diagnosis, while breast surgical excision is reserved for cases not amenable to image-guided biopsy, or if we need larger additional tissue to ensure adequate sampling. In many examples we'll mention later, inshallah. And look here, this is much less invasive ultrasound guided biopsy to the open surgical biopsy, more invasive technique. However, ultrasound guided false negative rate is only 0.1 to 2.5%. And there are many advantages of this we'll talk about later. Okay, regarding the radiologic histologic correlations, there are 5 possible outcomes described by Parikh and Tickman. The first is concordant malignancy. Here, the lesions suspicious both on imaging and the pathology confirm that the lesion is malignancy, and appropriate action should be taken without delay to proceed directly for prompt treatment of breast cancer. Discordant malignancy. In this case, imaging demonstrates benign abnormality, but pathology demonstrates that abnormality is being cancer. So management should be based on pathology and as if it is concordant malignancy without delay. Concordant benign. So lesions on imaging described as being benign, para 2, 3, or even 4A. Pathology proven the lesion to be benign. And there is also here some concern. You see, if it is a specific benign or non-specific benign lesion. When it is a specific benign lesions, it's okay. No need to go further, just a follow-up to ensure there is no, to make sure there is no cancer missed, okay, to determine the stability on the follow-up. While the non-specific type of lesions like fibrocystic, epicrine metaplasia, and these lesions, sometimes we might need to take a larger tissue samples, like with vacuum, to ensure that there is no underlying malignancy. Discordant benign. That means on imaging is suspicious, while pathology revealed a benign. So we have to make sure, is it really benign or not? We have to discuss with the pathologist. And we have to, most of the time, we have to take a larger samples, you see, by vacuum assisted or even open surgical excisions. biopsy. Why? Because it is proven to be up to 30.9% cancer in subsequent surgical excision in this group. If pathology revealed atypical ductal hyperplasia, lobular neoplasia, radial scar, papillary lesions, or possible phylloids, this is, we call it borderline high-risk lesions. By itself are not a malignant lesions, but considered to increase lifetime risk for development of breast cancer. They should be managed by a high-risk multidisciplinary team. Why? Sometimes might need to be excised. You see, some of these lesions might be associated with underlying malignancy. We mentioned we have specific and non-specific benign, the specific like fibroadenoma, papilloma, and so forth, non-specific like fibrocystic epicrine metaplasia, fibrous mastopathy, hyperplasia, and so forth. These examples of discordant benign lesions in an elderly patients, her mammogram revealed asymmetry, ultrasound revealed suspicious findings in the breast and axilla, and the biopsy revealed granulomatous mastitis. So for that discordant benign, they have done MRI and revealed inconsistent findings, and this is irregular hypo on T1 and T2 with surrounding edema extending to the prepectoral area with restricted diffusion and with type 3 washout curve. So all are features of malignancy, recommend rebiopsy, and revealed a lobular carcinoma. Mammography, ultrasound. When ultrasound and MRI use adjunct to mammography, they are offering a complementary informations. Each technique having its strengths and weakness to be the study of choice for certain pathology or certain abnormality, which is the best methods for each to evaluate each breast abnormality conditions. To answer these questions, there are many factors. First of all, the age. The most important is the age. Above 30 and below 30. Symptomatology, palpable abnormality, nipple discharge, skin changes, pain, whatever. And then refer back to the age. Risk factors. If the patient is younger than 30, having palpable abnormality, but she's a high-risk patient, we are going to start with mammography. Patient conditions. Pregnant lady, start by ultrasound. Very expensive to do for her mammography. So we have to proceed for ultrasound. The cost of the examination, it has to be considered. Sometimes the patient cannot afford to do that study. Availability of that technique, image technique, is it available or not? Expertise of the radiologist performing and interpreting the study, it has to be considered. And the potential contraindication and limitations that would prevent the patient use for a specific technique. So, but usually, routinely, we start as a common, we start by ultrasound, by mammography, I mean. In this case, having palpable abnormality and the patient, her age about 50, we have to start by mammography, revealed suspicious mass here with extensive at the lower breast side of her concern and extensive suspicious microcalcifications spanning at the lower part from the medial to outer breast, more appreciable here, the polymorphic, more appreciable in the magnifications image. And what will be the next step? Ultrasound. We have to proceed for ultrasound. Determine the size of this mass and to guide for biopsy. If the patient having a nipple discharge, mammography usually having not much role. It might demonstrate a solitary ductectasia, might demonstrate a nodule, small nodule, might demonstrate a group of calcifications, you see, indicate. But at the end, we have to proceed further. We have to look at this. And most of the time, it is unremarkable. So the standard reference for evaluation of ductal system, it was the conventional ductography, injecting the contrast if there is a single discharging duct. You see, through the orifice, injecting iodinated contrast medium, it will visualize or determine the phyllic defect intraductal pathology. Okay, and then proceed for the treatment, ductectomy or whatever. But nowadays, with high resolution, ultrasound is quickly becoming the new standard reference for evaluations of the suspected ductal abnormality and it is extant. However, sometimes it's difficult to differentiate if it is just an inspissated secretion or a real focal abnormality ductal lesions. Then we can use MRI for further characterization. Is really helpful. We can see the ductectasia and the ductal secretions component, as well as the enhancing intraductal lesions. And not only that, you see, this is the same patients, the conventional ductography, showing cutting of the ducts due to the intraductal lesions. However, here the whole extent of the ductectasia could be appreciated on MRI. And furthermore, not only central ductectasia, but also segmental ductectasia can be appreciated on MRI. So, as we mentioned, routinely we use mammogram as well as high resolution ultrasound. So, the outcome of these studies are four. It's either both are negative or both are positive, or mammogram positive, ultrasound negative, or the reverse ultrasound positive and mammography negative. And the final, generally, the final combined imaging assessment, it should be based on the most suspicious outcome assessment. And always we have to correlate it with the clinical. Both negative study, you see, having negative predictive value is 96%. So is not 100%. So no test or group test can ensure that the female having no breast cancer, especially if she has a clinical suspicion. If the clinical suspicion is high, they have to proceed for core needle biopsy based on the clinical suspicious area. But in case of the clinical suspicion, if it is just a low clinical suspicions, then the alternative will be an observation and follow-up, either clinical alone or clinical with imaging over 1 to 2 years to assess the stability. Okay. We mentioned clinical limitations for detection of early breast cancer since early days, and the surgical excisions. It was the only mean to diagnose breast cancer. And although technical improvement, technology improvement of radiology proven a great help in evaluation of breast disease and conditions, as we mentioned above, there is also limitations and is not 100% to evaluate and to exclude breast cancer. So the mastology patients should be managed or should require triple assessment: clinical examination, radiological assessment, and pathological evaluations. And the clinical practice guidelines recommend multidisciplinary approach to evaluate or to cancer care that bring together all relevant disciplines to discuss the optimal disease management, and especially for the breast cancer, which is heterogeneously complex, serious disease, and the modern breast cancer management become increasingly complex and specialized fundamentally, so it necessitates multidisciplinary approach management, which include surgeon, radiologists, pathologists, oncologists, clinical nurse, and all specialists in breast health care professionals. This definitely will reduce patient morbidity and avoid unnecessarily surgical procedure, preoperative cutaneous sampling, and re-excisions. So, start by mammography. For early diagnosis, allow early the early diagnosis allow early treatment and definitely better prognosis. So we should remember to start almost always by a mammogram showing a lesion. Not showing a lesions, proceed for ultrasound characterization of a lesion or demonstrations of a palpable abnormality not seen on mammography, and if it is showing cancer that need further local staging or not showing anything or problem solving, we might need to proceed for MRI. So the strategy of breast lesions imaging: mammogram, sonogram, MRI. And always we have to consider the clinical. Always we have to consider the clinical, and taking all together, you see, conveying into a one final impression category, and we have to consider the most suspicious imaging outcome assessment. And according to that, we will give the management recommendations. So, in conclusions, breast imaging plays a fundamental role, you see, especially breast and surrounding lymph node, extremely challenging, and the non-palpable abnormality are so common, and the breast imaging seeing numerous technological advances since early days of direct exposures film, and the main diagnosis monitoring technique, including basically mammogram, ultrasound, and MRI. The mainstay is mammogram supplemented by ultrasound and MRI. Relevance of ultrasound is increased, and modern clinical cancer treatment require precise positional information. The exact disease extension is really important, delineating any critical anatomical structure involvement. It will affect the treatment strategy, so we need high spatial resolution of our traditional anatomical methods, as well as the current new technologic breakthrough, imaging techniques, including molecular and optical imaging that consider a major clinical impact fighting against breast cancer. And the molecular imaging, as we mentioned, is newly evolving and emerging technique comparable to breast MRI performance, and because of radiation used only as alternate to MRI when it is not feasible or it is contraindicated, and because the breast cancer is very heterogeneous disease with diverse pattern of development, and response to treatment should be managed in multidisciplinary expert panel that definitely will reduce benign biopsy cost and morbidity. And thank you for attention.